Welcome everyone to the first HC Physicians Association webinar, where we'll hear about the HC Health Professions Advising with Dr. Miles Cahill, Health Professions Advisor and Chair of Committee. I'm Maura Sweeney, Director of Alumni, Career and Professional Development at Holy Cross, and I'm happy to welcome you to today's webinar. We'll be together for about an hour today. After the formal presentation, Miles will take questions from you for as long as time allows. In order to facilitate the Q&A, we'll ask participants to use the raise hand feature. Depending on how your Zoom account is set up, you might find that in the reactions section or by clicking on the participants tab. And we'll remind you again once we get to the Q&A. We also welcome questions and comments in the chat. This presentation is being recorded and will be made available to all participants in a few days. And now it's my pleasure to hand things over to Donna Lafontaine, who's our chair of the HC Physicians Association, and she will introduce Miles.
Great, thank you, Maura. I'm Donna Lafontaine. I graduated in the class of 1981, and I'd like to thank everyone for joining us tonight. It's such a beautiful night out there, and it's good to have you all here with us tonight. Since we have some newcomers, I just want to briefly raise one issue which frequently comes up, and it's why does this alumni group focus only on physicians? And the main answer is that it took several years to get this organization off the ground, and that was one major reason was because the scope was very broad. And so that being said, it's important to note that as we progress, it's our intention to collaborate with and include other healthcare professionals in many of our programs. And even tonight, you'll hear Miles address the entire scope of his health professional advising. One of the main missions of our group is to provide support and mentorship to Holy Cross students that are presently pursuing a career in medicine. And that's why we wanted Miles to start us off on our first webinar to create for us a general awareness of the current state of affairs. So hopefully at the end of his talk and in the future meetings and our future committee meetings, we can brainstorm and create truly valuable projects that will be specifically designed and help to support students based on the reality of what's occurring right now. So at this point, I'd like to introduce Dr. Miles Cahill, who's all going to start off by telling us his story of how he came to Holy Cross. And now I guess to Miles.
Thank you, Dr. Lafontaine. Thank you, everybody, for coming. It's my pleasure to be here. I know some of you, it's nice to see some familiar names come by, and it's nice to meet the rest of you. So I'll just start off by introducing who I am. I'm what used to be the pre-med advisor, now the health professions advisor. I'm the fifth in the history of the college since Father Bosom. My immediate predecessor was Andy Futterman. You know him. So this is something that's been, as you all know, long, very, very important to the college, really central to the heart and the mission of the college, and it's something that college has always strongly supported. So I'm a professor, a full professor in the Department of Economics and Accounting. I'm an economist, a labor economist. I've been here since 1995, so I'm finishing up year 26. I've been the director of the advising office since 2015. Before that, I was the associate advisor for 4 or 5 years, but I've been a committee member since 1998. So why me, an economist? I often get asked that, why an economics professor doing health professions advising, and my snarky answer is if you don't think there's a connection between money and medicine, then you might want to rethink things. The real answer is I really love advising. You know, as a professor, we're expected, well, we're evaluated on 3 basic things: our teaching, our scholarship, and our service. So we all take on roles to help the college community. And what I like best is to work individually with students, to mentor students and get to know their stories. It's really very inspiring for me. I'm actually now also I'm the speaker of the faculty. So I'm also the head of the faculty governance system right now. So that's my story. And anybody have any questions about that? Feel free to raise your hand. I've been teaching on Zoom all year, been running giant meetings all year, so I'm comfortable with the Zoom format. So if you want to, at any point, if you raise your virtual hand, if you know how to do that, or if that doesn't work, try the chat or just jump in. That's fine with me. So let me just give you a little update on how we're doing. I think at least basically the same as we've always done, which is really extraordinarily well. And that's a testament to our strong students for sure, and our strong faculty, our strong, especially in the sciences, but really across the board. So these are the last six years of data. So our long run average acceptance rate for medical school is about 83%. You can see this varies from year to year. So these are our recommended students for medical school. We have a few that apply without recommendation sometimes. And so you can see the acceptance rate has varied, roughly 75 to over 90%, depending on the year. The numbers, a high of around 50 and low. So what are we talking about? Low in the mid 30s or so. And this has been relatively consistent over a long period of time. What we have seen, I'll talk about in a little bit, is that students are more interested in other kinds of healthcare careers, and hence my title is Health Professions Advisor, not Pre-Med Advisor anymore. Our students are still very strong. So this is just in the last year or two, we've had acceptances at pretty competitive places, and I'll talk a little bit about how competitive medical school is now. And you're not familiar with it, you're probably going to be floored by just how tough it is to get in anywhere. But Harvard last year or so, Harvard, Columbia, WashU, NYU, UCLA, Brown, et cetera. Our students do very, very well, and they stack up. Our best students stack up with the best students of anywhere. And I hear that in their success when they go to medical school, and I more often hear it in their success when they're doing some sort of gap year or pre-medical school clinical job that maybe some of you have actually hired some of them and worked with some of them in your research projects or your clinics. They really do an extraordinary job. So what has changed? So what hasn't changed is that our graduates do very, very well in terms of getting into medical school and their success once they're there. What's changed is quite a bit. A big change happened in 2015. I know some of you are painfully aware of this. New courses were added to the MCAT. So the MCAT added 4 new courses, actually. They added biochemistry, statistics. So I know we had a question about, do we require statistics for pre-meds? Well, now it's required. And sociology and psychology. And so on the current MCAT, there are actually more sociology questions than there are organic chemistry questions. So it's really changed quite a bit. The exam time is 6.5 hours or 4 sections. There's no writing sample anymore if you had to endure that. The range is the same as it ever was. The old, like a 30 was a pretty good score, right? 15-point range in each section. The range is the same, but they've just rapidly, they greatly inflated the base number. So the average is now set to, was originally when they launched it, set to 500 and 125 in each section. Although since then it's crept up to around 501 or so. I think the biggest change I've seen in the last 20 something years is that admission is much more competitive than it used to be. There's a lot more emphasis on the MCAT and GPA. So our students, even with a little bit lower MCAT and GPA than average, they'll still get into good places. I know that our students are following your reputations as being excellent medical students and physicians. So I know Holy Cross applicants will get a look always, no matter what their numbers are. But it's beyond a doubt that expectations for MCAT score and GPA have gone up. So last year, if you know about the current scale, the average accepted MCAT score was a little over 512, which is like around the 83rd percentile of test takers, right? Nobody sits down for the MCAT for just a fun Saturday afternoon. Everybody who sits down is expecting to do well on it, and an average accepted MD student is going to have around a 512, which is enormously competitive. GPA is very strong, has to be strong. Admissions is more often done, I've found with rubrics and scoring rather than kind of on like a conversational or less formal basis. And that includes interviews. Interviews are often done with rubrics, and several medical schools are going to what's called an MMI, or multiple mini interview format, where the applicants will be subjected to usually around 8 short 5 or so minute interviews. They may be about a question, or they may be a scenario they're given that they're expected to react to or talk about, or they may be given a task to complete, and they're graded on a rubric scale that's used in scoring them in determining their competitiveness. There are new situational awareness tests. There's one called Casper, and then AAMC came out with another one. The way I put it is are you a sociopath test, to see if people are going to react appropriately or wildly inappropriately in certain situations. I call it why you a sociopath test, because the students actually never get the score back from these tests. The score goes to the schools, but they never know how they did. So what schools do is they just take extreme values. They're not worried about middle values. They're worried about really extreme values. That's when it's typically going to negatively impact an applicant. So admissions expect more. As I said before, the MD accepted MCAT is an 85th percentile now. Higher grades are expected. A- is expected for most MD schools, although our students get in with a little bit lower than that. Clinical experience is absolutely required. When I first started doing this, it was good and we recommended it, but it wasn't required. Now, significant clinical experience where the applicant has experience directly working with patients in some significant way is absolutely required. Volunteer experience can be part of this. Shadowing can be a little bit of a part of this, but because shadowing is essentially a passive activity, it's just watching. It's not highly valued by medical school admissions. I still recommend that students engage in shadowing, maybe as a first experience, just to make sure this is something they want to continue to pursue, and maybe to make a connection and get a mentoring relationship going. But in terms of being a competitive applicant, they really need to do something hands-on. And I actually think this is good. I think that they really need to fully experience a clinical environment before they make this huge decision. Another thing, I don't think I listed it here, but well, maybe I did. Medical school is just so expensive today and time consuming and stressful that it's not something that they should take on lightly. So schools are also looking for leadership, engagement, an interesting story. They got to apply really, really early in the cycle now, really in early June, not of the year they want to attend, but the year before. So sometimes schools now actually start at the end of June or beginning of July is pretty common now. So I'll say about a year before matriculation, they need to start their application. They usually apply to about 20 schools, and it's very common for private MD schools to get more than 10,000 applications. So like Loyola, I saw Father Musino is on here. They commonly get over 12,000 applications this year, over 15,000 applications. Tufts, 15,000 applications this year. And that's just for 100 seats, 200 seats at the most. So each school is extraordinarily competitive. So they really got to demonstrate they're ready to devote their life to caring for others as a physician. And all these things, the extra courses, the extra experiences, and being able to and demonstrating that they can do these things well, makes it really hard for a student to be able to do that, by the time they're 20 and a junior in college. So it's much more typical for them to apply a year after college. So we get a couple apply after their junior year, a couple after the senior year, but what's most typical now is to apply 1 year out, and I'll talk a little bit about why in a little bit. So here's growth in applicants over time. This isn't Holy Cross, this is national data. I don't know if you can see, I tried to color code it. So the black line is total applicants Let's see if I can even write on it, right? So this is total applicants. The blue line are male applicants. The orange line is female applicants. So the PowerPoint picked the colors for me. I didn't pick the colors. And then the dotted lines are the acceptance rate. So you can see now that the total acceptance rate is just over 40% of all applicants. If you talk to any admissions director, they'll tell you that there's an equal number of students that they didn't accept. They were just as good as the ones that they did accept. That is the way roughly the way I look at it is that 40% get in, they're all exceptional and add something. The next 40% probably looks the same on paper, at least in terms of their numbers and rough experiences. And then there's probably 20% that are applying just to try it or didn't get a good advice or something that just wouldn't be competitive to begin with. But it's an extraordinary competitive pool. The difference between the average accepted MCAT and not accepted MCAT, applicant MCAT is not that big. So this is 40%. If you applied in the around 1990 or so, is more like 60% of all applicants were accepted. But the 40% number has been relatively stable. This past year, though, people call it that your fellow alum, the Fauci effect. This past year, I shudder to see what the acceptance rate is going to be because more than 60,000 applied to medical school. Right. So the numbers here are on an average year for MD schools, a little more than 50,000 apply, and there's a little bit more than 20,000 seats for MD schools now. And this number, I'm sure you know better than me, is constrained by residency slots, which is really constrained by federal funding. It's not that the medical schools don't want to get bigger, or there are some new medical schools that have formed in the last few years, but they're constrained by residency rather than need or design. Notice that there are more women are applying than men today, and more women are attending than men today in medical school. And then this is MD. I'll show you DO numbers in a little bit. So another change has been the growth of osteopathic medicine. I'll show you a similar graph in a little bit. If you're, I know we have some DOs here on the call, which is great, because today I see very little difference between the two fields. In particular, their boards are converging. They're going to be essentially the same, a little bit different, but very close. Their residency accreditation are converging. DOs practice in every specialty. Every year now we get some applicants who prefer DO to MD, even they don't even apply to MD because they like the approach better. And the success of alumni in osteopathic medical schools is similar to allopathic medical schools. We had one this year who went to West Virginia School of Osteopathic Medicine, and she just matched at Brown for internal medicine. So Brown's MD residency. So I think osteopathic medical schools are just fine. They're essentially equivalent. Their expectations in terms of MCAT and GPA is a little bit lower. A point or a point and a half in each section of the MCAT lower, and a little bit lower GPA, but still very competitive. A little bit less competitive, but still extraordinarily competitive. The matriculation rates for DOs are about the same as MD, although probably some people get into both and decide to go to MD. We have quite a few. We've had a long history of applying to osteopathic medical schools, as many of you know, and great success. But we've seen a lot of growth in this area. DO schools. So for osteopathic physicians out there, students may be coming to you for mentoring and help because schools do want their applicants to articulate why they want to apply to osteopathic medical schools, so they can say a little something about the approach and why they're attracted to the approach, and they need a letter from a DO in order to be a successful applicant. Otherwise, all the expectations are the same. They tend to be a little bit more holistic in their review, so they sometimes seem to prefer a little bit older applicants. They're willing to give a little on the MCAT if it's made up or in other areas. It's just a little bit less numbers oriented, although numbers still matter to a degree. So here's the growth in DO. You can see, there were less than 5,000 applicants in the 90s. So, 60% acceptance rate around 1990, similar to, or I should say matriculation rate, similar to MD. And now we've got more than 20,000 applicants to osteopathic medical school. So, 20% of the MD applicants roughly, and with a starting class of just under 10,000. So a little bit less than 40% matriculation rate. Some of that are probably applicants who get into both MD and DO and decide to attend MD instead. So quick summary of development in the last several years. The students now have more courses required. The MCAT is longer. The scores seem to matter more. Grades matter more. Clinical experience is essential. It's not at all a box checking exercise. They really need something meaningful and talk about it. Talk about how it changed them. And that includes care experience. They have to show that they have a track record of caring for others. I don't think these are necessarily bad things, but it does make it tougher for an applicant. And both MD and DO are much more competitive, especially if you use the 1990 as a benchmark. There are more women in medicine. Medicine still struggles with diversity. There's no doubt about it. But because of all these things, because of the extra expectations, as well as I'll add, medical school is much more expensive today. Private medical schools are edging towards $100,000 a year for full cost of attendance. So tuition and fees, as well as living expensive, health insurance, things like that. So, this is a huge decision someone is going to make, a huge financial decision. It's like buying a big house that they're never going to live in most cases. And so they want to make sure that it's the right decision. And as you know, it's a very rewarding career, but it's also a very challenging career. They want to make sure that they're a good fit for it. So what have we done as a committee? So we have the same committee that you probably had to deal with. We have faculty. We have 8 faculty now from across the college. Some we've long had sciences as well as humanities. Our recommendations we've tightened them up a little bit to respond to the standards at medical schools. We see our role really as advising students and not so much screening students. That I talk all the time to admissions officers from medical schools. We belong to a group of 9 undergraduate colleges and 9 medical schools, and we actually, the undergraduate colleges, we Zoom every other week, and we meet twice a year with the medical school admissions folks too. So we get pretty good information about what medical schools are looking for. So we absolutely require clinical experience or a recommendation. We want a strong narrative where they're reflecting on their life experiences and how those experiences are leading them to devote themselves to caring for others as a physician. And we're looking for strong recommendation letters that speak to their core competencies that bode well for a medical school applicant. We offer more support for our students today because it's complicated and it's just more stuff. So we offer 4 years of advising. So we have 2 associate advisors whose role is to focus on helping the students early in their careers, so in their first and second years, formulate their academic plan, figure out how do they manage athletics with their pre-med requirements, study abroad, all those kinds of things. We have an associate director I see is on the call, Dr. Keith Musino, class of 74, who has been offering these really terrific workshops with discernment and interviewing and personal statements and a variety of ways to really support and help our students. He's worked tirelessly with many of our students as they work on their personal statements and interview skills. All these things are essential. We have a Kaplan course. We have a relationship with Kaplan, I should say, that we get a big discount with them because we have an institutional arrangement. We also get some aid to help them out. What I want to do is I want to make sure that each of our students has what they need to be successful. So I've been clear with Kaplan, I'm going to need some financial aid so that no student is not going to be able to afford, no student is going to be in a position of not being able to afford to take the class. That's my goal. So we don't get anything out of it. We pass everything on to the student. So what other changes have we seen? So health professions advising, because we've seen growing interest in other health fields. We've always had a strong pre-dental program. Nearly every applicant gets in. That's still true. Number of applicants have varied. Dental school is even more expensive than medical school, where more expensive dental school run you close to $130 a year for 4 years. So our applicants vary, sometimes 1, sometimes 8 or 9, maybe, possibly 10, but well fewer than medical applicants. Veterinary school, that's very expensive, and vets tend not to be that well paid anymore. But when I've talked to alumni veterinarians, what advice do I give to my pre-vet students? They say that human medicine, think about that instead. But we have a veterinarian on our committee who teaches in our biology department. So we do have students in, about 1 a year or so interested in vet school. But the real growth has been in allied health, mainly physician assistant and nurse practitioner. And we're seeing increasing numbers of incoming students interested in these fields. They're not really backup plans. PA school the requirements are different, but it's as competitive as medical school, by some measures more competitive, in that the acceptance rates are a little bit lower. So we have some pharmacy, physical therapy, occupational therapy, optometry, podiatry, all kinds of fields that our students are interested in. And they enter Holy Cross with these plans instead of them as being backup plans. So I'm seeing some questions here. Maybe I'll pause here and look at these questions. So the past year's numbers reflect students who later applied a second or third time and ultimately got in. Yeah, so the numbers you see are applicants for each year. So they're not, so meaning that those who applied in each year. So we do occasionally have people who apply a second or third time and might get in a subsequent time. We do very careful advising of those students for sure to identify what is the deficiency, if there was one, in them not getting acceptance, and work on those things. Typically they don't always listen, but we advise they take a year off and work on those things and then reapply. It's pretty rare. Most of our applicants are first time applicants. And amazing require clinical experience from a college grad, right? So where do they get them? They get it through summer internships. They get it through volunteering in local clinics. We have a volunteer program at the local free health clinic in Worcester, and we have a very big summer internship program. So if anyone is interested in expanding that further, that would be extremely helpful. Or they volunteer. We have, Worcester has 2 big hospitals, UMass and St. V's, and especially UMass, they volunteer a lot at UMass. We have another student-led program to volunteer with hospice patients. So actively dying patients, where the students basically, they just sit with them. They either a patient that doesn't have a family there with them, which is tragic and true sometimes. So the students will spend time with them, or to spell a family. But it's hard. So you see, this is one of the reasons why some need to take that gap year before application, because the schools don't want to see clinical experience in progress. They want to see it completed, right? So Nandy studying abroad was discouraged. Do they study abroad now? Yeah, they can. Yeah, we work hard to make it possible. It's absolutely possible to do, and so we've been advising students on how to do that. Throughout my time here. It certainly takes some logistical planning. They can't take their science classes when they're abroad, but it's a really valuable experience. So we encourage it. It does mean that they're definitely going to have at least one gap year. They won't be able to apply until at least the senior year. Actually, I had one student who finished all her requirements in 2 years, had everything, and then applied after her 3rd year while she was abroad. She was a superstar. obviously. Most are going to med school and straight from college, right? So now some years we have none. This, we may have 5 to 10% go straight through. 90% are going to have at least 1 year in the middle. Okay, so hi, Dr. Klein. What do the students who apply but are not accepted in medical school do? So they do a variety of things. So if they have a weakness, we try to work on that. Sometimes they decide they just want to do something else, and we get a good number. I get a good number who are relieved that they didn't get in because they really wanted to do something else. They really wanted to pursue research or something else. And for me, I'm suspicious that the reason they didn't get in was they didn't interview well. They weren't able to articulate why do they want to be a doc, and the reason is they didn't want to be a doctor. So that happens. That does happen every year. We get a couple like that. Although we try our best to make sure they've discerned carefully their decision. Some choose another healthcare field. So a variety of things. We don't give up on them. We will provide advising for as long as the student wants it. I have a class of 99 who applied the first time this year who might be reapplying next year, and I'm happy to help them. Research experience wasn't mentioned. So the question is that important? It can be helpful, but it's not essential unless they want to apply to a research-oriented medical school. So if they want to, certainly if they want to be a physician scientist, or if they want to apply to a school that is research-focused, like say Northwestern, then it is essential. But in general, it's not. It can be helpful, just like engaging in any activity, and any serious activity can be helpful, and it involves science, so that can be helpful to demonstrate their competency in science. But it's not absolutely essential. Clinical work is essential. Clinical research is often a nice combination because they work with patients and they work on a research project. Graduated 91, advised not to apply. Got a MA in medicine. Applied and didn't get in, worked for a year and ended up there. Yeah. So is it still common to get a master's degree in between? Well, so we do give our students a rating and feedback. I know this from being close with other undergraduate advisors that. Oops! Did my screen disappear?
Nope, you're still okay.
I'm still okay. Okay, I'm not seeing it for myself. Okay. So is that still okay, or is that different? Oh, it's different.
That's different.
Okay. All right. I can
there you go.
Make it good enough. Okay, that's weird. Yeah. If a student will sometimes come for advice because they know they're not quite ready, or the committee will say you're not quite ready, our lowest rating is wait to apply, and we'll give specific advice. So even if someone is at our different levels of recommendation, we'll always give advice as to what they can do to strengthen their application if that's what they want to do. So sometimes a master's degree can help. That's often very expensive though. So oftentimes just taking courses can be helpful. Sometimes they'll have it can be just as helpful. So what they need to do is show competency in applied sciences, and they can do that in the context of a master's degree, or they can do it, say, while working often in clinical research and taking classes in the evening. And there are some clinical research jobs that actually fund the students to do that. For example, Dana-Farber, where we send a lot of graduates, they'll actually give their clinical research coordinators money to take classes. So really, sometimes it just takes some applicants a little bit more time to get their academic credentials to a competitive level, to demonstrate that they're not just ready to handle the rigorous medicine, but so they can compete with the other many applicants out there. Interest in public health growing? Absolutely, there's interest in public health. We have some who apply to sometimes joint programs, MD and PH programs. At the college, we now have a health studies major, which has various flavors, and public health is one of them. So we have an advisor for public health. We have faculty interested in public health. We have couple of professors graduated or worked with public health PhD program. So served. So next one, I've served on our medical schools admissions committee. Would say that applicants who have had time between college and medical school are highly valued. Typically, they're more mature and more settled in their decision to go to medicine. Yeah, I think that's true. A student who really isn't ready, I can say to them, put yourself in the seat of an admissions officer looking at your file, a junior applying with good grades, pretty good score, did some activities, versus somebody who's a year out, has published papers on cancer research. They've been working with patients with brain cancer and working on a research study to try to help them. They've taken a couple of additional courses. They're more mature. They're every day they talk to patients who are stressed and from very different backgrounds. Who would you pick? Who would you choose? And that's part of the arms race that's happened is that to be competitive, you need more to be stronger. Are there 6-year MD programs out there? I'm not sure exactly what that means. So from college, is that college to MD? If that's under kind of BA or BS MD, there's a couple of them, but not too many of them. If you could describe a little more what you mean, let me know. There are some 3-year MD programs out there actually. NYU has their Long Island campus is a 3-year MD program where every entering student is automatically guaranteed a residency spot, and it's in a primary care specialty. So when they enter the medical school, they've already got their residency.
Dartmouth used to be one.
Dartmouth. So does that mean so you go to Dartmouth and then
After high school,
right.
You spend 6 years at Dartmouth, you get an MD degree. This is way okay.
Yeah.
I don't know anybody else who has that or not. But Brown
there's a couple. Brown has moved away from that a little bit. Brown has used to be mostly Brown Medical School used to be a lot of Brown undergraduate students, but they moved away from that a little bit. In general, I think students tend to be older, so I think there are fewer of those programs. We have relationships with a few medical schools where they can apply after their sophomore year and go straight in and usually avoid the MCAT. But I usually don't recommend it just because oftentimes 22 is young to make this big giant decision. 18 is really young to make that decision. So we have some ready to do that, right? We have some extraordinarily mature freshmen and sophomores, but it's pretty rare. Right. So questions about another question about medicine is such a popular field, but the economics of medicine is in such flux that it's surprising it's so popular. As an economist, I agree. What I will say, it's gratifying to me to see that our graduates who are applying to medical school, they're doing it because they genuinely want to help patients, right? They really want to care for patients, and that is driving them. And so they because we require medical schools require quite a bit of clinical experience. Medical schools want their first year students to come in with their eyes open and know it. So it's really what's driving the applicants is really a desire to care for others, which is a wonderful thing for me to see. It's moving for me, very inspirational for me. So there's a comment that BU had 6 and 7 year programs, and maybe they took a little time to ramp up. So early assurance program, yeah. So we do have a couple of early assurance programs. Okay, so we've had some questions of what applicants do, or now we're alumni do in gap years. I go over their record carefully with them when they're making decisions to try to figure out what to do. We had one one student who's going to Loyola next year. She played professional volleyball for 2 years. She wanted to get that out of her system. She's an extraordinary volleyball player, and so she played professional volleyball in Europe. So that's at one end of things. More typically, they're looking to solidify their academic credentials. So maybe they need to take a couple of courses, or sometimes sometimes they'll enroll in a full master's program, which is good, which is fine. It's just expensive, and it takes a full year. Usually they can't work and participate in these programs. Typically, they got to devote everything to it. It's a big gamble, right? They have to perform well in these programs. Some of the programs you're probably familiar with some of them. Some of them are essentially first-year med school classes, right? And they're throwing the students into the deep end to see how they do. If they do well, they prove they can handle med school. So that works. If they don't, well, they're out $50,000 or whatever it is. It's tough. So they'll take courses or sometimes enroll in a master's program, sometimes in a science area like physiology or anatomy or immunology. They'll often work in a clinical related area. Clinical research coordinator is probably the most common thing at a academic medical center, but also tons work as a medical assistant. It's really valuable for them to help out in an office or a hospital situation, or some kind of tech, like an ER tech or something, sometimes CNA even, just to get that basic care experience. Some will volunteer, so Jesuit Volunteer Corps, or there are a number of volunteer programs where they're caring for others, sometimes in a clinic or sometimes in a situation like a clinic, which can be valuable. And they do it sometimes to do something before they they pursue medicine, or to spend a little bit of time thinking, or to further strengthen their credentials. It's partly how competitive a school do they want to apply to be successful at. So some might get in after, if they apply as a junior, but they get into maybe a more competitive or higher profile program after. So this brings to how alumni can be helpful. I was asked to ask this. The clinical experiences are essential now for applicants. So if you can think of ways where you can offer our students or recent graduates clinical experiences, either in terms of work. I know Dr. Klein has had a GAP program for a number of years where he's hired recent or new graduates to work as endoscopy techs. That's been really terrific experiences for them. But even while they're students, if you can think of internships available at wherever you are, of any sort, especially if they have some kind of patient interaction, or medical assistant, technologist, what is especially helpful and attractive to them if it includes training. So this is a reason why so many take two years, two gap years, one so they can do something for that year, have it on their record, get a good recommendation letter, and then apply with that on their record, as opposed to being in progress. Being in progress doesn't help that much. And secondly, because jobs like CRC or medical assistant, well, it requires some training. And so their employer is going to want to get something out of that training. So they require a 2-year commitment, which I think is reasonable. So they have several months of training maybe for a complicated research study, and then they agree to be there for 2 years, where that second year is their application year. Mentoring is really helpful. So as mentioned, the economics of medicine are challenging. The bureaucracy of medicine is really challenging. There are lots of things that are highly challenging about medicine. Medicine has always been challenging. It's so challenging, I've had no interest in entering into it. So this gives me a little bit of power sometimes in advising, where I'll tell a student who I can tell really doesn't want to do it. Like, it's okay if you don't want to be a doctor. Like, it doesn't mean you're a bad person. I'm not a doctor. I don't think I'm a bad person. You wouldn't necessarily be a bad person, but really to reach this decision of, do they want to take on this awesome responsibility? It really takes a lot of work and a lot of conversations with a lot of people and a lot of experiences. So and anything you can offer in that way from full range. So give them the real deal, so that when they enter the field, they're entering it with their eyes open, but also support and encouragement, because so many highly accomplished physicians, maybe all of them, have suffered some sort of setback at some point. And so especially some of our current students and early graduates, they've had, they're worried that their 1C in organic chemistry at one point is going to sink their whole career, or mean they're not going to be a good doctor. And it's helpful for them to get encouragement as well. I've been kicking around ways, if you're interested in ways to interact with students in a way that might be productive and helpful, to provide some sort of structure. One idea I had is maybe a book club, where you'd read a book about something about medicine or the practice of medicine, and use that as a way to start a conversation with them. I do have physicians and surgeons come and talk to our students from time to time. They're usually really quiet. They sit there and they listen. They're I don't know, shy or something, or they're not likely to engage too much. So some kind of structure, like read Complications by Atul Gawande together or something, and talk about what it's like to train as a surgeon, or another breath becomes air, or something like that. I think that might be nice and helpful in a way to connect in a different way. So I'll stop sharing my screen here. And thank you for your question. I'll keep answering your questions. I'm happy to stay on for as long as you like. So I'll look at the text questions, and then feel free to raise your virtual hand, or you can even unmute yourself if you don't know how to do that. So work of doctorate. Okay, so there's a question: as the work of doctoring is moving further and further away from direct patient interaction, and the career of being a physician now includes so many other roles besides care delivery, how is the college preparing future physicians for this reality, especially for those who still choose a career for the service aspect? We want to make sure they know what they're getting into as much as possible by getting experience. I don't know how any other way to do it. We want them to really go into the decision clear-eyed. So this is, I think, one of the reasons we're seeing more of our students interested in allied health, like physician assistant, or nurse practitioner, or sometimes some of the other fields like optometry or podiatry, where they might be doing a little bit more patient-centered care. I'm not sure medical schools or residency even appropriately prepares for the true business of medicine. Yeah, probably not. Common. So when I ask alumni physicians for advice, the two most common pieces of advice I get are first, don't major in a science. So when I get advice for the undergraduates, this surprised me at first. Like, spend your 4 years doing something interesting, whatever you want. You're going to do plenty of science later. I usually amend that advice to say, major in a science if you love it, because majoring in a science in a college like Holy Cross gives you a chance to really explore the discipline, right? That science as a discipline, especially at Holy Cross, where we don't have graduate students. Our undergraduates work like graduate students. They work in the science labs. They publish papers. They become real scientists. So the second piece of advice is get some business experience. Get understand the nature of business and incentives and the like. So it's hard. The problem is it's hard for us to require any more classes, even if they're good ideas, right? They're already maxed out with half of their undergraduate curriculum is just getting ready for medical school in the MCAT, right? A typical student takes 32 courses, 15 are for medical school, right? And then they have a major. If they have we still have requirements at the college, a number of them. that don't overlap with the med school requirements, the language and philosophy and related studies, et cetera. And I encourage the students to think carefully about those choices. So we have some in philosophy and religious studies. We have some great ethics, medical ethics courses, things like that. But there's not a lot of room for them to add much extra in. So taking like a couple of accounting courses and economics course, unless that's what their major is, it's going to be challenging. Unfortunately, I say that with regret. Impressed with how prepared students who have contacted me through the network with insightful questions. Well, that's great. That's great. I'm glad to hear that. We like our, we're very lucky to have such a pool of really motivated, dedicated, articulated students for sure. Economics of paying more for med school and earning less. That's hard. It's really, really hard. So actually next week I have the Dartmouth Medical School is going to give a presentation to any Holy Cross student who wants to come, as well as our other affiliated liberal arts colleges, to talk about paying for medical school. It's hard. It's crushing debt. I don't know how else to say. They really, and this is part of why we make sure they really want to do it, right? They don't want to just try it out. My investment banking students, I say, try it out. See if you like working 100 hours a week and making a lot of money. Maybe you won't. If you don't like it, try something else. But medicine that's a different story for sure. Most graduating students coming out of general surgery residencies would rather be employed than go into private practice. So employed by a medical system or a private practice. It could be. I think getting getting a variety of perspectives from experienced alumni, physicians and surgeons is going to be very, very helpful for them to think about their long-term careers. It really, especially those who are already in medical school, right? So I'd love to set up a network to support the medical students and early residents to help them guide their careers going forward. That's perhaps even more valuable than helping undergraduates who are just trying to take all their courses and study for the MCAT and do enough experience to get in. Most doctors will be employed and not self-employed. That certainly seems to be a trend. Change management, behavioral psychology. So psychology is now a requirement for medical school. Team leader MBA-like courses. So Father Musino, maybe you want to spend a few minutes talking about some of the modules that you've been developing and trying to encourage our students to participate in. Some of them are about team building. That's one of your themes is they really have to demonstrate the ability to work in a team.
Yeah, if I could maybe back up on some of the other questions that talk about the variety of things that physicians are being asked to do. One of the things we're working on with students as they discern the validity of a career as a healthcare provider is to make sure that first it's their decision, that they are doing it not for their parents or what society or what economics or ego asks, but it's a true passion for them. But I also spend time with them trying to debunk the notion that there is one singular calling for them in one narrow niche or entity professionally, that I tend to emphasize that to live is to change and to live well is to have changed frequently. And what I'm trying to get at is to say that there's no singular destiny. You must continue to discern and adapt and move in the direction of the need that you want to respond to, what your skill sets and talents or abilities can address, and that you may move from a patient care provider to a systems manager if you can do that with grace and carrying on the modus of serving society that well. And so I ask them to befriend the God of trial and error and in adapting who they are to what they feel the call to do. And that seems to give them a freedom that society and their parents and the like are not empowering them with, to let themselves adapt and move in new directions. As many of your questions have suggested, the new crisis I'm seeing in young grads is when they can be in the dream practice that they have always wanted to be in, and within a year or two, they come with a crisis of business and economic tension, that they are serving the dollar. And that's a tough one. So I would like to advocate for having more health systems managers interact with students in medical school to give them a reality of what balancing the tensions of operational systems and economics and reimbursements and insurance and the like is about, where the health profession can also say, but what about integrity and the mission of true healthcare? So that's a new uncharted waters that I think in medical education needs to happen, because we can't dismiss it, they can't hide from it, and we don't want them bailing out of practice because they're standing toe to toe with a business manager that they don't have common and shared ground with. So those tend to be important things that I think are not yet fully addressed. And we'll get there, but we have to name them as realities. We have to see the data of the crises of students who say, you know, I'm so altruistic, but I can't do it in a practice. The question about a surgeon wanting to be in a healthcare system, not private practice. Well, we need to explore what that's about. Is that good news or bad news? And what's behind that that we can address to bear good fruit from that moving forward? I don't think we've done all the scratching of the surface of that. So that's why this is an exciting time in medical or pre-med education, to help our students to think about and to own what they're doing, and what they need to be about flexibly and adaptively going forward, to be aware of multiple stakeholders, multiple demands, and what their profession is going to ask of them, and how to feel true satisfaction in what they're doing, how to expand what gives them satisfaction. It might be that satisfaction is having a good day of meeting common ground with a business partner who sees things differently from you, rather than just having a patient say, I love having you as my doctor, which is a good thing. So we've got to explore all of that to make sure that they understand that, that what we're screening them for in terms of their instincts and altruism doesn't run aground of the demands and get chewed up by a system that asks more of them. And I think what better thing can we do as a Jesuit school than to have them adaptive and agile to work with all possible challenges and tensions.
Well, one of the things I tell our students is forget about what 2 letters or 3 letters or whatever, 5 letters are next to your name on your badge. What do you want to do every day? Like, what do you want to, you know, a day to look like? What do you want a good day at work to be? You know, what is that about? Is it responding to a chat here? Is it how many, you know, meeting your RVU quota? Or is it, you know, spending extra time with a patient, right? Is it doing something complicated, right? Is it really like, you know, complicated surgery that interests you? Or is it, you know, is it, you know, basic patient care? And so, you know, some will decide they want to pursue physician assistant or nurse practitioner or another field like that, or, you know, health systems or research, or, you know, a variety of careers. So I think one thing that sets Holy Cross apart from many other places is that we all view our work on the committee. I view my work as teaching and guiding and mentoring, and not trying to hit some number, not trying to hit an RVU, get a certain number into medicine. Is try to understand each student and alumni and alumnus where they are, and challenge them to think very carefully about this decision, make sure they've had challenging experiences, and then ultimately trust that they're making the right decision, and support them and help them find their path to where they're going. So that may mean talking, we just last week at our committee meeting, I think we just gave a 398 GPA student a weight rating. He wasn't ready. He's clearly not ready. And the way he wrote about his experiences and what his goals were. So we're not afraid to do that, even though, he may have gotten into a school somewhere, padded our statistics. We really want to care for each individual student so that, throughout their lifetime, as best as they can figure out at the age of 20 or 22 or 24, that they're making the best decision for them. So there's some other questions here about what do students do besides the things I listed, clinical research, medical assistant, et cetera, between college and med school, maybe just to make money. That's fine. If they have sufficient clinical experience, they can articulate why they want to be a physician. Their grades are fine. They could just get a job. There's absolutely nothing wrong with that. Get a job, make some money. That's totally fine. And do we prepare mock interviews? Father Musino has done, I don't even know how many mock interviews over the last year or so. Yes, we provide mock interviews. Career development will as well, and they're becoming increasingly important. I know we're at 8 o'clock, so I don't want to hold anybody on who doesn't want to, and I see people are leaving, which is fine. So maybe I'll turn it back over to Dr. Lafontaine, and I'm happy to stand with more questions. But if there's a wrap up, I don't want to deprive you of that.
The reality is you could probably go on forever and ever and ever, as our questions could go on forever too. So I just want to, on behalf of all of our audience here today, really would like to thank Miles and Father Muccio for sharing their expertise. I mean, it's been incredibly eye-opening, and I thought I had worked closely with medical students at my job, and I did, but there was so much of this I wasn't really knowledgeable about. So I think the benefit for us is that we've learned some ways tonight that we should be able to talk together in future meetings and future committees to find ways we can support, especially where you quote 90% of students taking gap years. We can, find ways to talk together to assist to getting those clinical experiences available to the students and the mentorship experiences. And especially I think Father Muccio had alluded to, we're very much in supporting both our students and our residencies. I mean, I think residencies are incredibly challenging times in a young doctor's career, and it would be nice to have a older shoulder to talk to, and so in talking with this presentation tonight, there's some great ideas that for the future we can bring hopefully to fruition. So I just wanted to let everyone know that if they had any further ideas or questions, is it okay to give your email, Dr. Cahill?
Sure, absolutely. I can put it in the chat.
Okay.
It's easy to find anyway.
All right, and in the chat, I'll put the email for the HC physicians at holycross.edu. So I think that would, so when we will certainly be having future discussions through the alumni physicians and anyone who wants to add or email one of us with some ideas, that will be great as well. And I think
so that thought of helping residents, I think that could be really helpful. I occasionally I'll have graduates in residency, call with a crisis and look for help. And when I can't really help them so much, I can only go so far. Being able to direct them to an alum is enormously helpful, because as you know, well, at least as I've heard, it's usually not so good to show a lot of weakness in residency or question. To have someone else outside the system that you can really talk honestly with can be extremely helpful.
Great.
I'll stick around if you want. There's some questions I haven't answered yet. I can do that quickly, but I will I won't push that. So anyway, sorry to interrupt. If you want to.
Oh no, I'm done.
Okay, great. So we're down to, thank you. We're down to one screen, so I can see if you raise your real hands too. So just quickly, the questions I haven't answered are about So about effort to the financial cost of medical school. So I have honest conversations with students all the time about the cost of it. And so one of the reasons to take a gap year sometimes is to strengthen your credentials so you can get into the state medical school, whatever the state is. And UMass is actually getting a little bit less state centered. They're taking more out of state applicants. But we have, as you know, we have applicants from around the country. So, think about that. If you take, and it's actually especially true for dental school sometimes. If you just take one more year and really strengthen things, you could be saving yourself hundreds of thousands of dollars. We have interest in military medicine for sure, who get an Army Health Scholarship or Navy. Actually, Navy has been most popular lately. And there's a National Health Service Corps as well. So I see a virtual hand up.
My husband just showed me how to do that.
Okay, there you go.
I had to, do you guys, Mike McGrath was my pre-med advisor. I don't know if that's,
Yeah, I know Mike. Yeah.
I had to speak when you just said that because I was lucky enough to get into the state school in my for downstate, but I really wanted to go to school in North Carolina, where I'd done something in a lab down there with my uncle.
Yeah.
Beautiful campus and everything else. And I found that he gave me one of the best pieces of advice that I appreciate to this day, was that I was trading off freedoms in the sense that by going to the state school, I had less tuition and had the freedom of making a lot of different choices, which were great, versus living in a place that had a lot more freedom. Like Brooklyn, New York is not a terrific place to go walk around the neighborhood, but I will always, be very grateful for that practical advice. And I just think for the students to always take that into account, especially with the kind of debt that they're taking on. I'm just wondering how you get them to stay motivated and wanting to help people when they're just, burdened by this ton of debt that they're not going to be making the kind of money, as I understand it, if they aren't hitting RVUs, et cetera, et cetera. But I'm not being cynical because I love what I did. I would do it again, but I'm just fascinated by this dynamic. And I did actually go on and get an MBA because I had that freedom to do another degree afterwards. I don't understand how they're staying true to their passion that they start with.
Yeah, it's hard. I don't have a good answer to that. I think that that sounds like a great topic for this group to think about. And if you have suggestions for us how we can help our students to think about those more carefully, that would be very helpful.
And they got to think about the money going into it. I can't imagine having all this great energy and then being crushed with $100,000 a year. I guess I didn't understand what's happened in the past 30 years.
That's with full cost of attendance. Yeah, Tufts is around 90 a year, and as I said, dental schools even more. The dental school varies more. So UConn is like 70 a year. NYU is like 130 a year for full cost of it. Wow. So there's a very big difference. Some of the state schools, right? The SUNY downstate, New York is a great state to be from because you have four state schools you can. UConn is also nice. Actually, UConn's great to apply for out of state because after a year you're a resident. So you're a Connecticut resident. In Massachusetts, you have to live for 7 years before you're considered a resident. So another question. I'm going to pronounce it wrong. Dr. Calopi.
Calopi. I was in Father Musino's pre-med class. I remember him. But I was an English major. So was my roommate John Mannion. But took all the requirements for med school, and I have to say that I'm very grateful to Mike McGrath. He was really a great help. But I've always felt, just from my exposure to patients, that they really appreciate that someone has the ability to explain things to them in plain English, and do so. And of course, nowadays you need to do so very succinctly because of the time. But that's one of the patient's biggest gripes. And so what follows from that statement is the question. It's going to be another statement at first. It seems to me that there ought to be a clinical track and then more of a research track, because I've done both of those things. And if you're in a clinical track, then the ability to explain things ought to be taught, in undergraduate to some degree, and it probably is to some degree. If you're in a research track, then the emphasis on science ought to be greater, and de-emphasizing the need to, be so particularly great with patients. And then, so my question is to you about what's your opinion about that. And I just also want to state that I decided, even back then, for cost reasons, to because I was on a work scholarship. I used to be a waiter in Kimball Hall, and all that. I decided to go with the Navy, and I don't regret that at all. The military medicine exposure and just experience in life helped me later. So that's all I have to say. And thank you for your response to what I've posed.
Yeah, we do have students who do, sometimes they want to bridge, but they do sort themselves out to really being serious, have a serious research career. And they may, then it's to make sure they want to do both, right? They want to be a physician researcher, because we have, occasionally we'll have somebody who wants to go to med school really for the credential, and so they can do medical research. And I say only go and get an MD if you really want to care for people, because it's expensive way. Even if you get into an MD PhD program that will cover your tuition, you're still spending 4 years and a lot of energy into that patient care aspect. But sure, we have internships that are more research based, and some that are much more clinical based. But that's a good point to encourage students to really think about their not just their technical skills, but really their communication skills, and make sure that those skills are appropriate to their ultimate career goals. We have, fortunately, with so much research happening on campus and so many opportunities to do research, they have to present their research on campus often. And they'll often go with their faculty to professional conferences to present research. They get good experience doing that. And then they will, when they give experiences to their friends that are academic conferences and the like, then they have to explain it in a way that their non-science friends have to.
And Paul, I was humbled by reading a personal statement of a student who did have a desire not to be an MD, PhD, but to continue to be pursue scientific inquiry while having a clinical practice. And she based that on shadowing a very research intensive clinician who became her hero because she brought the data of the research to the explanation she made to the patient. Now, I'll be honest with you, we need to make sure that a person who is heavily research oriented has the communication skills, but I will never ever again deny the fact that someone who knows the data of research does not bring a more enlightened understanding of complex drugs, therapeutic regimen, but the turn has to be how you express that in communication with patients. So I was humbled by that, to say it's not either or, you're either science or practice. You can be both, but our job is then to say, we don't want you to just be a science nerd. We want you to be a science informed, impactful, to use a word that all our millennials use right now, on your patients. So it's not either or to me anymore, that research and having a hand in that, if you're called to do it, can inform what you're about. And if you're not in research, my job in teaching you is still to make sure you're evidence-based in everything you say to a patient. Now, you don't have to be a bench researcher to be evidence-based, but I am thankful to that student who saw a researcher bring evidence-based to their compassionate practice.
So that's the kind of response, and also from Mike Cahill, that makes me proud to have graduated from Holy Cross. I felt that the undergraduate experience I had there and the preparation was just fantastic. And looking back, that does not change one bit. So I'm so glad to see the quality has been so well sustained and enhanced by such as what I've just heard tonight. So thank you.
And what I'll follow up on that, what really moves me is when I read these gushing letters, long letters from prominent researchers for our students who are applying, right? They've spent a couple of years doing research, and just about every single one is gushing and real, because our students are, you know, they're excellent, and I think they're excellent. So now I'm going to start bragging about them. They're excellent because they're willing to do like the basic tasks and grunt work things, right? Nothing is below them at first, but they're really smart and motivated. So they very quickly move up to you know, higher profile, more complicated, and ultimately supervisory tasks. So it's just great to see where I'll get this letter and say, well, you know, I asked him to look into this one thing, but he read all the research on it and then he came back with these ideas. So he brought him onto the research project. We get those things all the time. It's great to see. That's fun. Dr. Chevalier Horgan, nice to see you. I see your picture there, and I see a couple of comments there. I heard you just had match. Yeah, hi, it's so nice to see you. I was talking to your brother a couple of weeks ago, I think. He was going down to meet you for match day. So I hope that all went well.
I'm staying in New York for that, actually. So I'll be one of those residents that you're talking about needing a lot of support.
Great. Great. Well, I was very happy to see that this group has a full variety. I even saw some students, current students logged on, but also young physicians and residents, and as well as those who've been around for a while. So hopefully this will be a good connection for you. You're gonna be great. You're gonna be a superstar just like you were in medical school. I'm sure of it. Are there any other questions? Did I answer them? So comments about NEVI scholarships, other scholarships, and you had a academic fellowship, right? That you helped teach, right? And that helped to cover some of your costs.
Yes.
Can you hear me?
Yeah, we can.
Well, go ahead. I didn't mean to interrupt, but I'm just on a phone because I was on my way home from work when this started, so I didn't want to miss it. My name's Julie Miller. I too, as a Mike McGrath mentee, I guess. But one of the things that, just as a Holy Cross alumnus, one of the things I would also suggest is encouraging the pre-med, pre-dent, whatever, to do the Ignatian retreat, because so much of our pre-med time is a time of discernment. And that actually was a huge moment and a week for me to make the decision of medical school. And I think it just plays a really big role. And I think it's a huge part of it's a special part of being a Holy Cross student. And maybe just something to think about to encourage our students to do that.
And Julie, one thing we've done, when I first spoke to Miles about the opportunity of coming back to Holy Cross and spoke with the provost, she said, I love the prospects of what you can do in pre-health professions, but could I ask you a special favor to deal with not only early pre-health profession students who are trying to figure out what they want to do, but any student who is seriously considering, or as we would call it, discerning what is their pathway in life and how do they become their best self. So Miles and I have been working on, and I began piloting this year, offering programs with a discernment process that doesn't require you go to the Joyce Center, or when I was here going to the 5-day at Gloucester, which ended up making me a Jesuit by virtue of that. But saying it doesn't have to be a retreat. It can be whole. It can be a, how do I make good decisions in life in a discerning way? So we're trying to roll that out with our students right now. And I have to say, with the few students who have just been piloted with it, to look in their eyes and see what doing that, even over Zoom, when it's not about a retreat in a so-called holy place, a retreat house, but it's about talking to them about making their best decisions and giving them Ignatian skills of how to understand their own self-deceptions, the temptations of society, the pressures of economics, the temptations of discouragement and disillusionment, and having them be their best self. We're doing that.
That's excellent. Good.
Great. And any other question? I'm happy to make the slides available if that'd be helpful. I think Maura, you have them, right? So you can make them available. Sure.
Yes, I do.
Yeah. Great. Anything else? All right. Well, thank you so much. I really
you.
appreciate
Thank
this
you.
opportunity.
Thank
It's
you.
great to see what happens after they leave our. Thank you.
Thanks.